sleep apnea, obesity. These are things that we can control, and it's very important to do that the best that we can. And I'll talk a little bit about what we can do, or what you guys can do to help to kind of modify those things. On the hemorrhagic side, these are a little bit more difficult to correct. Hypertension or high blood pressure is obviously something that we work very hardly to correct. But things like vascular malformations, which are more genetic, aneurysms are more genetic. Those are types of things that you have a little less control over. But if they are found by a health professional, there's things that we can do to help to prevent those problems from giving you some type of hemorrhagic stroke in the future. So what can you do? What can you do to help to manage your risk for stroke? The biggest thing I would say is to make sure that you're seeing your primary physician as regularly as you can. Get your blood pressure checked, get some blood work, check your cholesterol, make sure you're not becoming diabetic. If you tend to snore at night or develop sleep apnea, that's something that can also be addressed by your primary doctor doing sleep studies. I know that during COVID, since COVID hit, it's been very difficult for people to get in to see their physicians, and I completely understand that. And I know people are fearful to go to the hospital. And I just want to say that since this has all started in March, there's been a lot of changes that have been made throughout the healthcare field or system in order to get people access to care. And it may not be face-to-face in the same room, but things like virtual office visits and things like that, they can still help to manage these risk factors for you. Get you on blood pressure medication or cholesterol medication to help adjust your risk factors. The other things that you can do yourself is to make sure that you're eating a good diet. Not one thing versus the other, but having a balanced diet of healthy fats, healthy carbohydrates, proteins, making sure that you're exercising as much as you can. They recommend 30 minutes, 5 days a week. That's what the American Heart Association recommends. And it doesn't have to be, sprinting or anything. It's just getting outside, walking, brisk walk, a light jog, things like that, get the heart rate going. Quitting smoking, avoiding avoiding any drug abuse, things like that. So what can you do, or how do you identify a stroke? Strokes can be very tricky to identify. Commonly or classically, we tend to think of strokes as things that cause a facial droop, weakness in an arm, affecting this, your speech becomes slurred or very confused. So that's your kind of common, and honestly, and probably the most common type of stroke that we see because of the blood vessel that gets affected. But there's other types of strokes that can occur too that are a little less common, and I think a little bit less well known. And those are ones that can affect your balance. You can have vertigo or dizziness, spinning sensation. Things, you could have loss of vision on one side of your visual fields or in one eye versus the other. Confusion and severe headaches. Now, those tend to come with more of your hemorrhagic or bleeding type strokes. Those tend to make people have a headache and more confusion, but you can get those as well with an ischemic stroke as well. But those are the most common one is going to be facial droop, slurred speech, arm, leg weakness or numbness. So if you notice that you're having those types of things, it's definitely time to act as soon as you notice them. So what do you do if you're having a stroke? The most important thing you can do is to get to the hospital. Call 911, get an ambulance to you, let them, unless you're sitting right outside the door of the ER when it happens, I think it's the best to call an ambulance and have an ambulance come get you, because the paramedics that see you, they can call us, give us a heads up that you're coming. They can start an IV, they can start, medications to help in the treatment of stroke before you even get to the hospital. And but the biggest thing that you can do is get to us. And And the same thing with the TIA or a mini stroke. If you had something happen where you had a facial droop and an arm weakness or numbness, and it went away, um, I always get fearful for people that are, that don't want to come to the hospital because they feel fine now. But that's to me is a big warning sign that something could be coming in the near future. And I'd rather you come to the hospital, let us look at you, let us evaluate you and see if there's something that we can correct or identify that would prevent you from having a stroke in the future. So I put this up. I always find that this number is always, very, surprising to me and astonishing to me. But for every minute that a stroke goes untreated, so that the brain goes without any oxygen or blood flow, 1.9 million brain cells are lost. So as you can see, the faster you can get to us, the more brain cells that we can potentially salvage, and the less effect that the stroke will have on you in the future. So the treatment for a stroke. So a lot of times the treatment for what we can do for a stroke comes down to how quickly you get to us. So the quicker you get to us, the more treatment options that are available for us than for somebody that might come in. If somebody comes in within a couple of hours, we have a lot more treatment options to help to correct that stroke or to treat that stroke than somebody that comes in or waits a couple of days. And if you come in within a certain time frame, there's a medication called tissue plasminogen activator, or TPA is typically what we use for short. It's basically a clot busting medication, and we give it through the IV, and the idea is that it goes in and it breaks up the clot that's blocking the blood flow to the brain. Recently, in the last 6 years, 5 or 6 years or so, we've done something called a mechanical thrombectomy. And this is something, as you can kind of see in the short clip there, where we are actually able to get into the artery, usually through the groin, and kind of route a device up into the arteries of the brain. And we're able to physically remove that clot from the circulation. And this has been shown to be very, very beneficial. But again, we have to do it within a certain time frame. So we need people to get there as fast as they can, as soon as they recognize it, for us to be able to do these types of procedures and to be able to help the best that we can. Aside from those types of things, which tend to be kind of the more acute or the more rapid treatments that we do, typically if you have a stroke and you come to the hospital, you're going to be admitted. We're going to do quite a few tests to try to decipher exactly why you had the stroke. Where did it come from? Is it a problem with the heart, such as atrial fibrillation, which is a heart arrhythmia that can put you at risk for strokes? Is it because you have blockages in the arteries in the neck, and do we need to address those and put stents in? So you may be put on certain medications to help prevent strokes in the future: aspirin, clopidogrel, which is Plavix, or certain anticoagulation medications such as warfarin, apixaban, or rivaroxaban, which are known as Coumadin, Eliquis, or Xarelto. And this would be determined by your healthcare team when you come in as to which treatment would be best for you. And then getting back to risk factor modification. So looking at your blood pressure, your cholesterol, diabetes, making sure that those things are under control. I think, Michelle, you were going to talk about post-stroke care. Oh, Michelle, I think you're on. Oh, are you on mute? Sorry, I can't hear you. Maybe you're not. Go ahead. Can you?
No, not yet.
Yeah, you got it on mute now.
Right. And now I don't.
There you go.
You're back.
Okay. Hi. Okay. So my name is Michelle, and I'm the stroke coordinator at Henry Ford Macomb, and I work hand in hand with Dr. Muir. And we're just going to talk about some post-stroke care. Sometimes people will think that after you have a stroke, your life has to be changed forever. As Dr. Muir was just talking about, the need for speed and fast assessment and coming to the hospital, preferably 911, always will determine the best outcome for you. So after a stroke, you're probably going to find you're going to have to learn new things, such as maybe dressing, driving, shopping, all those things, to name a few. Just if you always want to make sure that you're doing what you can, they're going to become second nature to you. 10% of stroke survivors recover almost completely, and that is with therapy, and we'll discuss that in the next slide. 1/4 of the patients recover with minor impairment, and then 40% experience moderate to severe impairment. Next slide.
Sorry.
So post-care stroke care. So the long-term goal of rehabilitation is to really help the stroke survivor become as independent and as functional as they were what we call prior to baseline status. Our ideal way of wanting to do this is to make sure that we are doing everything to get you back into as independent as possible. And the basic skills of bathing, eating, dressing, and walking always preserves the dignity and the independence. As much as possible, we always strive to get you back to your prior level of function, whether it be with assistive devices, whether it be with learning maybe not to use your right hand as much as your left. But the more that you deal with the post-care, the more it will come as second nature to you. Rehabilitation usually starts at the hospital after a stroke. The earlier, the better. And rehab is one of the things that is really going to drive your ability to return to a normal state prior to admission functionality. Next slide. So when we talk about post-stroke care, usually we have a few different options. Some people prefer a rehab unit in the hospital with inpatient therapy. Typically, we call that inpatient rehab. It really is for people that can tolerate about 3 hours of pretty intense therapy, and we kind of split it up during the day. It's not all 3 hours at once, but that typically gets you, it puts everything back together. We certainly want everything to reunite. And so when you go to the inpatient rehab, and we have inpatient rehab at Henry Ford, I know most hospitals, they do have inpatient rehab. And that really is to the point that they're really working to push you and just get you back to where you were prior to your functional level. And then if you don't meet criteria, and this really truly is all dependent on insurance as well, or the need that we feel that you're able to. If you're really not able to take the inpatient rehab, which is pretty intense, they might refer you to a subacute care unit. I know a lot of people used to call them nursing homes and things of that nature, but it's really not. A subacute care unit has usually, different beds that are for patients that come for rehab and they go home. So whenever anybody says subacute rehab, please don't think that means a nursing home. It just means that your care is going to be a little bit more prolonged and you need a slower pace. A rehabilitation hospital with individualized inpatient therapy is also an option. Home therapy is an option, home with home health care, keeping in mind that typically they make 3 to 5 visits a week and it's not really as intense, but at least you're in your home. And a lot of folks right now are really deciding to do something with home therapy, because typically right now with the subacute care units and issues of visitation and stuff, they'd just rather be home. And then returning home and then seeking outpatient therapy at a different facility. You would go there probably 3 to 5 times a week. They would work on the issues that seem to be most pertinent, that we want to autocorrect to get you back on the way to your prior function. And if we're talking about statistics, we know that 10% of stroke survivors recover almost completely, and another 10%, they require care in a nursing home or a long-term care facility. That goes hand in hand with either one, waiting too long, the type of stroke, the intervention that we were able to provide for you. So actually, we always know the sooner the better. That always has a great outcome. 1/4% recover with minor impairments, and 40% experience moderate to severe impairments. So with the post-stroke care, there is life, there is hope after a stroke. We can work you up, and as we mentioned in the slide before, rehab is actually started right while you're in the hospital. We start trying to build your strength, and we start trying to work on the things that if you have right side neglect, we're trying to get you all the occupational therapy, physical therapy, speech therapy in the event that you're having difficulty swallowing or word finding. So we start that initially right away because we want that to be carried on, and the sooner you start, the better. Stroke recovery can really seem overwhelming, but the rehabilitation is where you regain your strength, your courage, and your independence. We do have with always good resources is stroke.org. And Life After Stroke, they have really nice kits and things there that are very informational and that would help you out, be it you're the patient or a caregiver.
Okay.
All right. We actually had a couple questions come in the chat already. The first question is, if you think someone is having a stroke, of course, you're going to call EMS, but should you give aspirin while waiting for them to arrive?
I would say no, because we don't know if it's a bleeding stroke or if it's one of the ischemic strokes. So if it's a bleeding stroke, there's potential that giving an aspirin could make the bleeding worse. So I think the best thing you can do is just call EMS and get to us so that we can kind of do our tests and treat you there at the hospital.
And then the next question is, can you explain how sleep apnea is related to stroke risk?
Okay. So yeah, sleep apnea. I'm not 100% sure on the exact mechanism. I'm not sure that there's a known exact mechanism for how it's related. But we do know that sleep apnea, basically in the middle of your sleep, you stop breathing for a brief period of time. So you tend to have these episodes where the amount of oxygen in your body decreases, and there's certain organs in the body that are less tolerant to that decreased amount of oxygen, the heart being one, and the brain as well. And there's also the way that you breathe. When you are having sleep apnea can put you at risk for developing heart failure and atrial fibrillation, which both can have a direct impact on risk for stroke. So again, I don't know the exact mechanism, but it's a known risk factor for both stroke and heart attack.
So there was a question, how detrimental is it? It's one of the risk factors, but there are lots.
Yes, yeah. I mean, it's one of the risk factors. I wouldn't. I would say that the ones that tend to be more heavily concentrated on are blood pressure, cholesterol, diabetes is a really big one, and smoking. Those tend to be the real big ones that we tend to concentrate on the most. Um, but sleep apnea is definitely something that we look at as well.
You can keep those questions coming. And I had a question. And why would you use the mechanical treatment versus the medicine-based treatment?
So the mechanical treatment is for specific causes of stroke. If there's a very large blood clot that we are able to identify when you come in, then they're able to go in and grab that blood clot. It tends to be in order to get that treatment done, it takes a lot more time because you have to be moved from, usually you're in the ER up to our cath lab, and then have to have the procedure done. So it takes a little bit longer to get you to that point, and it's only indicated for certain types of strokes that we identify a very large blood clot that we can get to. The medication is actually indicated in all strokes that come in that meet certain criteria. So you might actually get both. If you come in, you have a big stroke, you come in within a certain time period, we look at the criteria for using the medication, and you meet those criteria, we might give you that medication, very quickly. And then, we also may do the thrombectomy later, or soon after, if you also meet the criteria for that.
There was a question, if you could go back one slide to leave up the website about
Oh, sure.
stroke care. And then another question, if there are any procedures to forecast the likelihood for a stroke?
Well, I think, if you look at, we always look at, the carotid arteries as a source of possible, blood clots going into the brain. They don't recommend right now routine screening for those blockages unless you start having symptoms. But if you do, if you are found to have blockages in the neck, I mean, that can be an indicator that you may have a stroke in the future. But most of it comes down to risk factors, and a lot of times family history. Family history is a really big risk factor, where we look at, certain families, they have a high propensity for heart attacks and strokes, and it's just something that is kind of more familial or genetic. And
how far out would you go with your family, like just your own parents, or?
Usually we say first degree relative. Yeah, so like a family member, like a mom, dad, brother, sister type of relative. Yeah. But a lot of times it'll run, from generation to generation, grandfather, mother to you. I mean, a lot of times it goes generational.
There's a question about what advantages does Henry Ford Macomb Hospital offer for stroke treatment?
Well, Henry Ford, we're one of the top stroke centers in the area. We work very closely, with Henry Ford Maine as well, and have dedicated stroke neurologists and stroke interventionalists at Henry Ford in Detroit. But we have a very good stroke program with regard to treatment. When you come into the emergency department, we have some of the fastest treatment times in the area. A couple of years ago, the American Heart Association gives out awards for certain performances that each hospital does, and in 2019 we won the highest award. In the last 10 years, we've been what we call our honor roll Target Stroke Honor Roll Elite. And we have a very good also post-stroke care program with our rehab, inpatient rehab. Michelle might be able to talk a little bit more about the rehab, but we have a very good post-stroke care program as well.
Do you want to jump in, Michelle? Oh, it went off again. If you want to do the mute, unmute thing.
Yeah. Can you hear me now?
Yep, you're back.
I'm back. Yay. Okay. So in our inpatient rehab therapy, they're located on Unit 45, and we have a fantastic area where we actually have like half of a car. We do baking, we do dexterity movement, we have speech pathologists. We have the stairs if you were needing to get more familiar with the stairs. I think our inpatient rehab therapy is one of the most desirable, if I had to say. The quality of the department is very highly focused and everyone is very engaged, and the staff there are tremendous at really kind of trying to scoot you through it. Even though you might have a little bit of, I don't really want to, they're right there to kind of give you that gusto of, yes, you can do it. Yes, you can do it. It's not a no. But they work really, really hard. They have their own educational sessions that they go to so they can specialize in the stroke training. And we do have dedicated, physical therapists, occupational therapists, and speech therapists that work specifically with the stroke patients. So that is kind of like their niche. They know everything about what needs to be done, and they're very ingrained in what they do, and they're fantastic.
Michelle, if there is somebody who is caring for a person who is in recovery from a stroke, like if it's their family member, their parent, their spouse, do you have any advice for someone who is taking care of someone who is staying at home or has come home after therapy?
Well, if they're going to be at home with home care, that is something that they can actually see what they're actually doing so they can be part of that. I think the biggest thing that I would really recommend is we always have to remember the caregiver as well. It's very hard on the caregiver as well as it is on your loved one. So we have support groups through Henry Ford Macomb, and we have them through Henry Ford Maine, and they're very, very good because, you know, caregiver, you've got that uneasy, you have that uneasy feeling. Now, there are some places that once they get able and, you know, ready to push forward a little bit, there's also many places that you can go to, whether it be in Macomb or wherever, almost, I don't want to say like a day program, but it kind of still lets you utilize and socialize depending on the severity. And you always have to have that caregiver. You're very compassionate, but you also have to take care of yourself, and you also have to keep the spirit up and keep encouraging. So it's always good that you're taking care of yourself, you're taking time. I would recommend at least, 2 times a week, maybe, have someone come and stay with the loved one so you can get out, either go get your hair done or whatever you need to do, just to have some time for yourself so you're able to give back, to your loved one, because it causes a lot of compassion fatigue. They've talked about that in studies a lot. And it's very important that, you take some time for yourself as well. Sometimes we need to take a step back to take a step forward for the next day.
And if somebody is, not really sure that they want to visit the hospital or don't really know about visiting, a rehab every day, can you talk about some of the changes that have taken place at the hospital, like the different procedures or what somebody would expect if they were to come to the hospital now? during COVID?
Yeah. So, unfortunately, in the last few weeks, we've had a little bit of an uptick in the number of cases. So the hospital, Henry Ford Macomb and Henry Ford Health System in general, has right now restricted visitors, except for some in specific individuals or specific circumstances. I know that in the ER, there's been restrictions on visitors, any visitors coming back for quite some time. Now, a lot of times, it's impossible, or we need family members there to help us to get histories for people, or to get medication lists, or for information. Or if somebody doesn't, if somebody's got dementia or is unable to speak, or speaks a different language, sometimes we'll have family come back to help us, so that we can interact and communicate. But it's right now, especially, they've been really restricting any visitation in the hospital.
If somebody is going in, should they have like a card prepared or anything, or
That, as far as like what kind of medications they're on and
yeah,
things like that. A lot of people do that, and it is very helpful, because then we can kind of just look at this card. We can know the medications, what the dose is, what medical problems people have. So that is definitely helpful. But we always like to talk. A lot of times those cards can get outdated, so we're always confirming what's on them.
sure.
But it is helpful to us.
I don't see any other questions, but we're happy to take them. So if you thought of something, let us know. And I'm just going to throw out there too. So the Clinton-Macomb Library is the home to the Macomb Library for the Blind and Physically Handicapped. I think the name is changing, and while they primarily serve people with visual disabilities, and it sounds like visual disability could be a consequence of having a stroke.
Yep.
But they do also serve people who can no longer physically hold books and turn pages. So if there's someone who's caring for someone who has had a stroke and has lost that dexterity, they may be eligible to get audiobooks in the mail for free through the Macomb Library for the Blind and Physically Handicapped, MLBPH, which is part of the National Library Service. So if you're here because you're a reader and you've got someone in your life, that's something that you might want to look out for them. I also threw into the chat some information about the vaccine at Henry Ford. And
Yeah, if anybody has any questions that's not related to stroke, I'm happy to try to answer those as well. I'm not going to say that I'm a COVID expert, but I've seen quite a bit of it, and so if you have any questions about that, I'm happy to try to answer your questions.
yeah, because you said you're based in the emergency room.
Yep. So I've seen quite a bit of of COVID, probably more than I wanted to. Especially in our community, we got hit really hard initially, and a few other times, in November, and now again we're getting a little bit of an uptick, not quite as bad as it was before, but the thing I think that I would want to really stress is that early on there was a lot of fear of people coming to the hospital because of COVID, and I actually saw a lot of stroke patients that were too scared to come in and get evaluated for very large strokes that really affected their ability to live their life. And by the time they had gotten there, it was too late for us to really do anything to try to reverse the stroke. And it really made me feel terrible for those people, and I know that a lot of it was people were trying to stay out of the hospital because they knew that the hospitals were overwhelmed with COVID at the time. And I can tell you that now Things are not like that. We've learned a lot over the last year. We've learned how to treat COVID a lot better. We've got a lot better therapies. We're getting people in and out of the hospital a lot quicker. And the hospital is not nearly as full as it was at the time. And just because COVID's here doesn't mean that other emergencies don't happen. And we're prepared to treat anything, that comes through the door. So if you think you're having a stroke, heart attack, anything, see us. Come see us. We've got protocols in place to keep people safe. Keep, if somebody does have COVID in the hospital, we have them isolated. So just that's just kind of my little.
Don't wait. Oh, Michelle, I don't know.
Better.
Yeah.
Better? Okay. There is also, I know we mentioned it a little bit yesterday, on the Henry Ford website, there's also some really good information about COVID. So if you went to either, henryford.com, there's great articles, recent information, different up-to-date issues that you might find very helpful as well.
Yeah, it's always nice when you can go to one source and know that, like, okay, this information is coming from a health system. It's not just someone on the internet. This is someone from our community on the internet. So I think I put up just a general website.
Okay.
And then, are you doing vaccines through Henry Ford? Do you have any advice about the vaccines?
I'm trying to remember the last thing I saw. I know that the Henry Ford's going to be getting, or has just gotten, the Johnson & Johnson vaccine. They've started to, so I know that we've started to offer it to the inpatients for those that want it, which I absolutely encourage people to get it. I got it myself back in January. And the Johnson & Johnson's a little bit different than the Pfizer and the Moderna, but they all work kind of on the same grounds. They do not contain any live virus of COVID. You do not get COVID from it. I know the Moderna and the Pfizer, they basically use an mRNA vaccine, which is more or less an instruction booklet. You're basically getting injected with the instructions on how to make your body to make one of the proteins that sticks out on the outside of the virus. And what that does is it allows your immune system to recognize that protein, and your body will say, oh, this is not something that we're used to seeing. It's something foreign to us, so we're going to build an immunity to it. And that way, if you do come into contact with the actual virus, your body's already seen it. You've already got an immunity build up. You've already got the soldiers there, so it doesn't have a chance to become an issue. So that that's the Moderna and Pfizer. The Johnson & Johnson uses a viral vector, which is basically, it's not the COVID virus. It's kind of like a created virus, but made in a lab that just has it almost the exact same thing. It just has the instructions for the body to make this protein again. So they work very similarly. I know I had the thing up in front of me. I know that the Pfizer and Moderna were two shots. I think the Johnson & Johnson is one. But yeah, Henry Ford is offering it to their inpatients. I know that.
Well, if nobody has any other questions, I thank all of our attendees for coming, and thank you to Dr. Muir and Michelle for being with us. We are recording this, so if you wanted to refer to it, we'll put it up on the library's YouTube page, and I'll send out that link to all of our attendees tonight so that you can share it if you want to. And be well.
Stay well, and thank you for your time.
Thank you all very much.